How are you? My name is Temptations Matenga. I am a sonographer at United Flower Hospitals in Zimbabwe. So today we're going to talk about ultrasound imaging of superficial lesions, and to be specific, lumps and bumps. Good day. My name is Temptations Matenga. I'm a sonographer at United Flower Hospitals in Zimbabwe. Today we're going to talk about ultrasound imaging of superficial lesions. And to be specific, we're going to talk about the lumps and bumps. There are so many lumps and bumps that I'm not going to be able to exhaust all of them, but I'll try to talk about the most common lumps and bumps that we encounter in our clinical practice. So what is your role as a sonographer? What is the role of this ultrasound modality? The role is not to give the definitive diagnosis, but do not quote me wrong. I'm not saying that ultrasound cannot give a definitive diagnosis in lumps and bumps, but that is not its main role. But in some cases, we might be able to give definitive diagnosis. But its main role is to identify potentially aggressive neoplasms so that we minimize excessive imaging and invasive procedures, especially patients who have benign lesions. And there are some general rules when imaging these lumps and bumps. You need to have focused history of your lesion. This is where you're asking things like their multiplicity, the duration of the lesion, the rate at which it's growing, is there any associated pain, was there any prior trauma, clinically, are there any symptoms of infection, does the patient has a history of anticoagulation or any systemic illness or malignant. Then you also do physical examination because you need to correlate your findings on physical palpation with ultrasound findings. So in physical examination, you need to get to know the size of the lesion that you're dealing with. You need to know the firmness of the lesion. You need to know whether the lesion is mobile or not. Is there any associated tenderness when you're palpating the lesion? Are there any skin changes? Then on technical details, on transducer frequency, when we're imaging the superficial part, we use the high frequency. And when we're imaging the thigh and trunk, because we need a deep penetration, we use a low frequency transducer. Then we need to optimize our color Doppler. Let's maximize our Doppler sensitivity by reducing the scale of our Doppler and also increasing the gain. And we also need to reduce pressure. You will notice that some of these superficial lumps and bumps, they've got very tiny blood vessels. So if you compress, if you put any pressure on them, you are now collapsing the blood vessels. And when you turn on your color Doppler, you won't pick up any flow. Not that there is no flow, but because they've compressed the lesion. So try and reduce pressure as much as you can. You might also need to use extended field of view in cases where you're dealing with large lesions. And apply amount of gel, especially when you're dealing with the lesion that's on the dermal layer. You need to apply amount of gel and also apply light touch. Just a few acquisition tips to the ones that you already know. You need to gain confidence of the normal anatomy first so that you can identify the abnormal. So you might consider scanning away from the affected area so that you get trust and you get assessment of normal anatomy, then you work towards your lesion. And always keep your gain low and keep the depth deep enough to see the underlying fascial planes. Because some of these lesions might reach fascial planes, so you need to know to see the extent of your lesion. Otherwise, use color Doppler to assess your vascularity. And on describing our lesion, the ultrasound descriptors that we use include anatomical location, the relation of this lesion to the fascia, vessels, and names, joints or bones, if there are any. Then you need to note down the size of your lesion, and you need to check on the morphology of your lesion. Is your lesion cystic? Is it solid? Or are we dealing with a mixed lesion? You need to look at the shape of the lesion. How are the borders of your lesion in their margin? Are there any acoustic features? What do you see posterior to the lesion? Is there any enhancement or is there any shadowing? Are you seeing any associated calcifications inside your lesion? And how is your vascularity? You need to note down all of that. So some of the benign lesions that we might be dealing with when you're dealing with these lumps and bumps include cysts, the most common ones, which are Abscess and Ganglion cyst. And another most common benign lesion also is a lipoma, superficial lipoma. We might also get cases of vascular malformation. We might also encounter muscle hernia, sometimes foreign body granulomas. We might deal with superficial fibromatosis, lesions like peripheral nerve sheath tumors, and in other cases, hematoma or seroma. Then the malignant lesions that we usually encounter are the lymphoma, soft tissue sarcoma, and you might also get metastasis from distant primary tumor. So just the protocol that you might use when you are dealing with these lumps and bumps. So when you identify a possible mass on clinical examination and on ultrasound, sometimes, as I mentioned earlier, the ultrasound can sometimes give a specific diagnosis. In cases where, for example, in cases where we are dealing with foreign bodies, we were dealing with a hernia, we were dealing with the ganglion cyst, a lymph node, a bone or a calcification, epidermal cyst or abscess. Then in other cases, hematoma. And you will notice that on hematoma, there are question marks there. You realize later why we put question mark on hematoma. So when you encounter a mass-like lesion and it is greater than 5 centimeters or deep, you might need to recommend further evaluation by other imaging modalities. For example, you might need to recommend MRI for extremities or CT scan for chest or abdomen. And if your lesion is superficial and it's less than 5 centimeters, you need to look at the characteristics of this lesion on ultrasound. If the characteristics are not of a lipoma, you might need to recommend excision or biopsy or even MRI for further evaluation. But if they are characteristic of a lipoma, you might just need to follow it up clinically or even with ultrasound. Or you might recommend excision because some of these patients are not comfortable staying with these lumps and bumps, so they might just need them to be removed. And if you get no ultrasound abnormality, but your exam is suspicious, you need to recommend further evaluation with other imaging modalities. So one thing that you need to know is the limitation of ultrasound as a modality. It is not a superhero. So it's not going to do justice in all the lesions that you're going to encounter or in all the clinical presentations of patients. So you need to know where your ultrasound is limited and recommend other imaging modalities that are superior to ultrasound, for example, MRI or CT scan, so that we do justice to the lesion that we're dealing with, or to the patient rather. So our first teaching point of the day is when you encounter densely shadowing lesions, recommend X-ray for further evaluation, because most of these are bone growth. So you can just pick them up on an X-ray. So you can just recommend to do an X-ray so that you see the lesion that you're dealing with. First of all, we need to appreciate the normal anatomy first, so that we'll be able to identify the abnormality. So this is just the ultrasound pattern of the normal superficial structures. We have our skin, which is echogenic, this layer. We also have got our subcutaneous layer. This is subcutaneous fat, and it is usually hypoechoic. Its thickness varies based on body habitats. Then we got our muscle, which has got middle level in echoes, and it has this lamellar pattern. So in between, we've got this fascia, which appears hyperechoic. All right. So moving on to our first benign lesion, as I mentioned earlier, this is the most common ganglion system, the most common, and the most commonly seen in the wrist. So typically they're round and they're oval, and they contain jelly-like fluid. So because of this, we expect this to be anechoic on ultrasound. Sometimes they can be hypoechoic, and they have well-defined margins. But however, they might demonstrate internal secretion. And because it's a cyst, we expect to see posterior enhancement, occurring enhancement posterior to the cystic lesion. And these are just images showing us the cyst. This is the clinical picture. So we don't pick any color flow on Doppler scan because we are dealing with a cyst here. But we have a teaching point when we're dealing with cyst. Whenever you encounter a cyst in an area that you are not expecting to see a cyst, you need to be suspicious. The three images that are shown in this slide is the same image. And you will notice that on the first image, you actually think that we are dealing with the lesion, which is anechoic. So you might be quick to think that this is a cyst. But what happens when you now optimize your grayscale imaging? You will notice that, okay, there is actually some stuff inside our lesion. It's not anechoic, right? Then you put on your color Doppler, you are actually picking flow. So we're dealing with the solid lesion here. And if we did not optimize our color Doppler, and if we did not if we did not optimize our grayscale imaging, and if we did not make use of our color Doppler, we might have mistaken this for a cyst. So always remember to optimize your grayscale imaging and turn on your color Doppler, especially if you see a cyst where you are not expecting to see one. Then moving on to epidermal inclusion cysts. These are found in the dermal layer or sometimes in the subcutaneous layer, and they're slowly growing. Usually they are not painful, and they get this pseudotestis sign, and you see the attachment to the dermal layer. They are well defined, and we might get, we might see the tract leading to the skin, but it's not always as easy to get the tract. As literature says, practically you might not be able to get this tract, but if you get one, you will see it leading to the skin. On color Doppler, we're not supposed to see any color flow, but you might get artifact signal from the contents of the cyst itself. It then becomes a problem, or it then becomes a bit complicated when this cyst ruptures. This tract that we're saying is not as easy as it seems to pick, now becomes oblique. So it now becomes even more difficult to pick this tract. And usually, patient presents with painful symptoms. And due to this rupture and the pain, we might get focal inflammation of the area around the cyst, as seen in these images, that there's inflammation around our ruptured cyst. So because it is ruptured, it now is an irregular bud. But this can be confused for a very aggressive lesion. So you need to know the history of your lump so that you don't confuse this with an aggressive lesion when it's just a ruptured ganglion cyst. Moving on, we also have got fat necrosis. This is fat and is located in the subcutaneous fat, and you also need to correlate with clinical symptoms. Most of them attend. So you will notice that clinical symptoms keep on coming up. So you can't image lumps and bumps without the clinical history of your patient. The clinical history is going to guide you on your differential diagnosis for you to narrow down the differential diagnosis. So you cannot start scanning a lump without knowing the history. Just take as much history as you can so that you know what you're dealing with and you narrow down your differentials. On ultrasound, this can be hyperechoic, it can be hypoechoic, or it can be heterogeneous. And those are some of the differentials, including lipomas, seromas, hematomas, and pseudoaneurysm. And if you follow this lesion up, with time it will blend with fat. So these are just some images showing this fat necrosis. So you see that the appearances are very different. Some of them are hypoechoic, some of them are hyperechoic, some of them are hypoechoic. So it just depends. Then we move on to abscess. This also have got several signs. And some of these signs include an irregular border, and it has posterior acoustic enhancement. This is just fluid collection, so we expect to see acoustic enhancement posterior to the abscess. And echogenicity ranges from hyperechoic to anechoic, depending on the abscess that we're dealing with. And if we put compression with transducer, we expect to see movement and swelling of the contents inside the abscess. And it might be associated with cellulitis. So we might get edema and phoboston appearance around the abscess on the subcutaneous tissue surrounding the abscess. And if we use color Doppler, it allows us to visualize the vascular structures near an abscess, but there's no flow that is fast enough to cause a color signal inside the abscess itself. So these are just some images showing abscesses. So you will see that the appearance differs with the range of appearance of these abscesses. And this is the phoboston appearance that we're talking about due to cellulitis. This is the huge abscess. All these are abscesses. So you need your clinical history, and you can also have guidelines that we were saying earlier that there is enhancement posterior to it, as this is fluid collection, is noted in most of these images. Then we move on to hematoma. So hematomas can be maybe acute, and they may also be chronic. So the contents of the hematoma can vary from a fresh hemorrhage to chronic hemoglobin degradation products, depending at the stage that we're imaging our hematoma. So this also means the physical consistency varies. It may vary from hyperechoic pure lipid collection when it's still fresh, and it can also be chronic solidified mass when it's now at an advanced stage. And sometimes it can actually be mixed. And it is very difficult to give a definitive diagnosis of a fluid collection as a hematoma basing on ultrasound appearances only. You need to get clinical history of trauma for you to diagnose a fluid collection as a hematoma. Because hematomas and abscesses, sometimes they appear similar on ultrasound. So clinical history is the one that is going to guide you whether you're dealing with a hematoma or you're dealing with an abscess. But literature says when ultrasound misdiagnosis is the cause of delayed diagnosis of sarcoma, muscle hematoma or muscle tear is the most common misdiagnosis. So what does this teach you or tell you as a sonographer? Whenever you see a hematoma, you need an explanation for it. You need significant history of trauma or a patient taking anticoagulation. And if there's any doubt, just follow it up. With time, hematoma changes its appearance and its consistency, the physical consistency changes. Or rather just do a biopsy, especially if you follow it up and you don't see any changes, so that we don't miss these sarcomas and delay the treatment and diagnosis of these sarcomas. Moving on to muscles, the lumps and bumps that we might be dealing with when we are looking at muscles include traumatic rupture or herniation. Sometimes they also get these hematomas and abscesses that we're talking about. They also get the infection, myositis ossificans, and sometimes neoplasms. So when dealing with muscle hernia, the advantage of ultrasound is you have the dynamic maneuver of the patient at rest and at stress to aid in your diagnosis. And when you're examining your patient, it is preferred that you use light pressure so that you do not reduce the hernia. And as you notice in most of these pictures, these hernias are very small. So if you put any pressure on them, you're going to reduce them, and you won't pick them up, you will miss them. So just use light pressure And sometimes contraction of the involved muscle actually help you to reveal the lesion or accentuate it. And the herniated muscle and adjacent non-herniated muscle are less echogenic than the normal tissue. And this is possibly due to anisotropy or maybe atrophy due to the repetitive trauma due to the herniation of this muscle. Sometimes the hernia can assume a mushroom shape as seen here when it protrudes through the defect. And sometimes the only subtle evidence of this muscle hernia that we can see is just focal thinning and slight elevation of the fascia. So most of the time it is overlooked, but that will be our only clue to diagnose the muscle hernia. So you need to be very careful when you think you're dealing with a muscle hernia. Just you need to be attentive to every little detail that you might get. Moving on to superficial fibromatosis, these are typically small and they are slow growing. And they include palmar fibromatosis, plantar fibromatosis, juvenile aponeurotic fibroma, and infantile digital fibroma. Their preferred imaging modality of choice is MRI, but ultrasound sometimes is used. And the role of imaging mainly is to describe the location, the anatomical location of this fibromatosis, the extent of the lesion that we're dealing with, and its relation to adjacent structures, especially the vital ones like vessels and veins. And on ultrasound, they appear hypoechoic or it can have mixed echogenicity. And on color Doppler, they are hypervascular. On real-time elastography, it shows blue color with a green color, which shows a moderate hard nature and moderately low elasticity when comparing it to the surrounding tissue. Moving on to foreign body granulomas. So the appearance depends on the foreign body that we're dealing with, right? What is the material that we're dealing with? What is the size and where is it located? Usually we use the high frequency linear transducer greater than 10 megahertz. And typically they appear echogenic, the foreign bodies, and we get posterior shadowing, acoustic shadowing posterior to the foreign body. Sometimes they appear as the foreign body granuloma appears as a hypoechoic halo that can consist of a hematoma, of edema, or sometimes granulation tissue is seen in these images. These are our hypoechoic halo. So this could be hematoma, this could be edema, depending on the foreign body that we're dealing with. And as mentioned earlier, we also get vascular malformation. And when we're dealing with vascular malformations, color and spectral Doppler are very crucial. But most of the time, they are limited due to patient motion and cooperation, especially if we're dealing with pediatric patients and geriatric patients. They might not be as cooperative as we want. So it might be difficult for us to employ this color and spectral Doppler. And also use compressions, because remember we might be dealing with venous malformations as well. So the vascular malformations that we might encounter include capillary malformations, we might get lymphatic malformations, venous malformations, and arterio-venous malformations, and sometimes arterio-venous fistula. And to talk about arterio-venous malformations, we'll see multiple dilated arteries and veins with color Doppler, but not always do we see them on grayscale. You will notice that when we're dealing with AV malformations of deeper structures like uterus, the only clue that can make you diagnose it is when you turn on your color Doppler. But on grayscale, you might not even pick in abnormality. And sometimes there won't be any discrete soft tissue mass. So your Doppler is your clue. So as seen in the images, on color Doppler, we're seeing the tortuous veins in the arteries. And when we turn on our spectral, we get our spectral waveform of the artery and the vein as well. Then moving on to venous malformations. Clinically, on the area where we have this venous malformation, it is light to blue. and it ends by light compression because this is the vein. So when we compress the vein ends. So this light to blue color disappears. There's no through or root in this home, and usually it's not painful unless if there's a thrombosis, and it can arise from any tissue, even including the bone. On ultrasound, we will see our well-defined hypoechoic heterogeneous sponge-like mass, and it is poorly marginated. All right, so venous malformation, clinically, the area of this venous malformation is light to dark blue, and it ends by light compression. When you compress, the veins are empty. There is no true or root in this home, and they are not painful from patient unless if there's a thrombus. And this can arise from any tissue, including the bone itself. On ultrasound, we see all defined hypoechoic heterogeneous sponge-like mass in their poorly marginated collection of veins, and there's isoechoic thickening of the subcutaneous tissue. Because we're dealing with veins, they are compressible with transducer pressure, and in 16% of the cases, there's phlebitis, and in 84% of the cases, there's low velocity venous flow, and sometimes in 16% we don't get flow, there's absent flow. So these are just some images showing this venous malformation. So you see that there is low velocity flow on this image where we tend on color Doppler, and sometimes there is no flow, there is no velocity flow on this one. Okay, moving on to lymphatic malformation. We can get macrocystic lymphatic malformation. Sometimes they can be microcystic, and in some cases they can be combined. So in macrocystic, these are huge cysts. They are large cysts, and they are separated by septa. We might get debris within the cyst. If we turn on our color Doppler, we're only supposed to see the flow, the arterial and venous flow in the septa, not in the cystic contents themselves. As seen in this image, we are seeing the uptake of flow in the septations of our cystic lesion. So these are images showing macrocystic lymphatic malformation with the cystic hygroma in this case. Then we also get microcystic. So these are very small, that sometimes you might not even see them. They might not be visible. In, for example, when you're dealing with fibromatosis disease in breast, in early stages, we might not see any abnormalities, but just increased echogenicity. So they are usually hyperechoic as seen in this image, and they're ill-defined. So we say our cysts are small, less than 1 centimeter, that they might not be visible. And we also said we can give combined, we have our macrocystic and the microcystic in the same lesion is demonstrated on these images. Then moving on to fibroadipose vascular anomaly. This is a complex combined low flow vascular malformation, and oftenly it involves the forearm or the calf. So there is anomalous veins within the muscle and adjacent subcutaneous soft tissue mixed with fibrofatty tissue as seen in this image. And it affects any age, but usually worsens in adolescence. And it is usually associated with severe pain. So there's hyperechoic mass replacing the normal fibrillar pattern of the muscle. This normal fibrillar pattern on the other side is replaced by this hyperechoic mass as seen in this image. The hyperechoic mass, which is demarcated by the stars. So we see our dilated intramuscular and subcutaneous veins. These are the dilated intramuscular veins. There are veins here, but we're not seeing them because they're not dilated and because they are normal. But on this region, we can see them because they are dilated. Moving on to infantile hemangioma. It is a well-defined soft tissue mass. As you can see here, we can clearly define this mass. And if echogenicity varies, we might get calcification sometimes, but they are very rare. If we turn on our color Doppler, we expect to see hypervascularity as seen in these images. And we get both arterial and venous flow. And on the arteries, there is high velocity flow, which can actually reach up to 28.4 centimeters per second. That is the mean velocity. So as is seen in this image, our spectral waveform of the arterial flow is showing very good peak systolic velocity. These are other images showing the increased color flow on Doppler scan and our good peak systolic velocity. So as seen in this image, this is actually approximately around 50 centimeters per second, high velocity flow. These are also other images. Then moving on to the lipoma, this is the most common. So this is the most common soft tissue mass, and clinically it is rubbery and small growing, and it affects people of the age between 40 to 60, sometimes found in children, but it is very rare. And in 5% of the patients, it is sometimes multiple, and it is not usually painful, except for angiolipomas. So these are images showing lipomas. So on ultrasound, they can either be hyperechoic, they can be isoechoic, or sometimes they can be hypoechoic. And they've got smooth borders, but these smooth borders are better visualized on real-time imaging. Sometimes on a static image, you might not appreciate them. And we don't get any refractive shadowing as seen in these images. We don't get any refractive or edge shadowing, and there's no deep shadowing posterior to the lesion. It might actually instead show acoustic enhancement. As seen in this one, you can see posterior acoustic enhancement. And color Doppler can be minimal, or we cannot pick any Doppler signal. So there's these wavy echogenic lines, internal lines, and the wider than taller. They are found in the subcutaneous layer. We don't find them in the intradermal layer. If we find them, then they are not lipomas. So they are usually oval or lobulated when we are looking at the shape of it. So as in all these lesions are lipomas, but as you can see, the echogenicity varies. This is actually hypoechoic to almost anechoic. This is a bit on the hyperechoic side. This is isoechoic. This is isoechoic, that is almost blending with the subcutaneous tissue that you might actually not be able to pick it up. So echogenicity varies. Moving on to liposarcoma. This is now a malignant lesion. And most frequently, it affects the deep soft tissue masses of the extremities in 65 to 75% of the cases. Then in about 51% of the cases, it affects the lower extremity, that is particularly the thigh. And it can also be seen in the retroperitoneum, which is the second most common location, in about 20 to 33%. Then the upper extremity also follows as the third most common. And we can also get them in other less frequent locations. For example, the head and neck in about 5% of the cases, and sometimes the trunk in about 4% of the cases. And most of the time they're intramuscular, but they may also arise intermuscular or sometimes subcutaneous. So we might get them on the subcutaneous location. So these are just various images showing these liposarcomas. And as noted in these images, most of these liposarcomas are huge. And as you see here, we actually get to use the low frequency transducer because of this huge deep liposarcoma. This was also a low frequency transducer. So these are just some images showing you the liposarcomas that you might encounter. Then moving on to peripheral nerve-shaped tumors, ultrasound cannot differentiate between neurofibromas and schwannomas. And they appear hypoechoic. with through transmission, that you might actually get posterior enhancement. So you might mistake it for a cyst. So it might sometimes simulate a cyst. But in other cases, you might get nerve continuity, which is your clue that you're dealing with a peripheral nerve system. But it's not always easy to get it, but you might get the continuity of the nerve. And there is presence of color flow on Doppler scan. Moving on to intramuscular myxoma. This is a slowly growing mass, slowly enlarging mass, and it may be painful. So on ultrasound, it is a well-defined hypoechoic to near anechoic lesion as seen on this one, and often shows the heterogeneous echo texture in some of the cases, most of the cases. Yeah. So we might get posterior enhancement in some cases, not in all of the cases. As seen here, there's posterior enhancement, and here also there's posterior enhancement. And you might get internal echoes in some of the cases. They might be increased through transmission. In 85% of the cases, there's a sonographic bridging, this one, around the mass, right, which is called the peripheral rim of echogenicity. And when we turn on our color Doppler, it is hypovascular or avascular, as seen on this image where there's color Doppler. This one, we'll see that it is almost avascular. There is this blood flow, which is hypovascular. We don't expect to see increased vascularity in a myxoma. So what are some of our suspicious features that you might see when we're dealing with these soft tissue masses? If you see any mass that is greater than 5 centimeters or deep in location, that is a suspicious feature. Or if this lesion is painful or it's enlarging, the mass is enlarging, is also a suspicious feature. And if we get any lipoma with internal heterogeneity, when you encounter a solid heterogeneous mass, which is distorting the tissue and shows disorganized or on color Doppler, that is a suspicious feature. And if we are looking at the margins and they are infiltrated, that is also a suspicious feature. And if this mass of ours is now bridging the fascial plane, that also is another suspicious feature. And if we get internal calcifications, we might need to do an X-ray first, but that is also a suspicious feature. So as mentioned earlier, if it's greater than 5 centimeters or deep, we might need to recommend further imaging modalities like CT and MRI and excision or biopsy if it's less than 5 centimeters and superficial and it's not characteristic of a lipoma, or clinical follow-up if it's characteristic of a lipoma and it's less than 5 centimeters. So what is our teaching point? Once we detect a lesion that does not fall into a very specific typical pattern, we will need to biopsy for us to get a definitive diagnosis. Remember when we started, we say the main role of ultrasound is not to give definitive diagnosis. Most of the time we get definitive diagnosis by biopsy. So if you are seeing anything that is suspicious, you might just need to recommend biopsy so that we get a definitive diagnosis. Also, don't forget to look deeper, because some of these lesions, as mentioned earlier, they might bridge fascial planes. When you look at the image shown on the slide, if someone did not look deeper, they might have missed this, which just looks like a shadowing or an anechoic space when we're using this high frequency transducer. But when we now turn on to our low frequency transducer and we look deep, you will see that we're dealing with a mass here, which was confirmed by CT scan. So don't forget to look deeper. So there are questions that you need to ask yourself when you're done with your procedure. One thing that you might know, that you want to know is, as a sonographer, you need to appreciate the limitations of you as a person, you as a sonographer. You need to appreciate the limitation of the machine that you're using. Because remember, these ultrasound machines, they've got different contrast, they've got different quality when dealing with this superficial lesion. So you need to know the limitations of your machine. And the third thing, you need to know the limitation of sonography, ultrasound as a modality. As we mentioned earlier, it's not a superhero. So in some of the cases, it is limited. So you need to know all these three limitations. So after you're done with your examination, you need to ask yourself these questions so that you see if your exam is sufficient for you to obtain a diagnosis. So some of the questions, the first question is, was the site clear? And did you see the extent of your lesion? Did you see all of your lesion? And are you able to give a definitive diagnosis of this lesion? If any of the answer to these questions is no, then you might need to recommend either further imaging modalities, or you might need to recommend a specialist referral, second opinion from a specialist colleague. As I said, you need to know your limitation. So you might be limited as a person, not the modality or the machine itself. So just refer it to your special colleague so that we can help the patient better. On report writing, you might need to include the brief history of the patient and the examination that you did, but this is not compulsory, but it helps, especially if the patient is referred to someone else who was not the referring doctor. Then you outline your findings. What did you see on ultrasound? Then after that, you need to give a summary statement. Were you able to get a diagnosis? If yes, then you need to give your diagnosis if possible. If not, you might need to give a recommendation. What is the next move for this patient if applicable? Does this patient need to go for further evaluation with an imaging modality? Do you think we need to do biopsy? Or do you think you need a second opinion from someone? So just put a recommendation after you're done. So in conclusion, these soft tissue masses have non-specific appearance, as you have seen. But do not worry about this. As we said, your main role as a sonographer, or the main role of the ultrasound imaging modality, is not to give a definitive diagnosis, but is to give a guideline of the lesion that we're dealing with. Where is it located? Are there any suspicious features? Do we need to follow this lesion up? Do we need to recommend further imaging modalities? And high-frequency transducer can actually help characterize the echo-pattern better, as most of these are superficial. So high-frequency transducer has got better penetration and better contrast, so it can characterize the echo pattern of our imaging of our lesion better. And the etiology clues might be hidden in the location in the clinical history. So we cannot stress enough that you need the clinical history of the patient and the lamb that you are dealing with for you to get the clue of what you are dealing with. So just get as much clinical history as you can. Don't overlook this. And most of the time, ultrasound is used as the first imaging modality, as this help triage patients towards further imaging or biopsy or sometimes surgery. Thank you so much.